Thanks, Brant. Thanks, John, for asking me to give this talk, one of my favorite subjects. So hopefully I'll inspire some love of the topic in you as well. So this is supposed to be a master's class. I was kind of appalled to learn I was in the master's category, but I guess I do have the gray hair. One of my fellows said, well, at least you don't have to update your bibliography and on your slides, but I did anyway. So disclosures, as indicated, none of which have any impact on what I'm going to discuss. So achalasia is a funny disease. It presents with a wide spectrum of disease. In fact, it's very rare that I ever see a patient that comes in that doesn't come in with an initial diagnosis of GERD as a catch-all. So these patients very frequently have GERD-like symptoms. They get sucked into the GERD chain, placed on PPIs, treated for sometimes a long period of time for reflux disease, or sometimes asthma or some other side effects. But in the end, dysphagia kind of rises to the top, so these patients start developing problems with swallowing, regurgitation, spitting up. Odd thing about it is it's often their families that bring them in, and often they don't. It's a disease that's chronic. It happens very slowly, and these symptoms, they're often in, I don't know if denial is the right thing, but adaptation, if you will. So often it's their family that can't take them to a restaurant. They come in, their initial history when you take it might say, I have some heartburn. Do you ever have trouble swallowing? No, not at all. Do you ever regurgitate? No, not at all. Their wife sitting beside them, or their husband rolling their eyes. And then you have to kind of coax out of them what's really going on. They'll say, oh yeah, but every time I eat, I have to go up to the sink and spit up a little bit. So don't regurgitate, but I spit up after every meal. So a good history is very fundamental to taking care of these patients, and it can take a little bit to drag the history out of them. Workup's very standardized. These patients need an endoscopy. They can have pseudoachalasia, of course, rare, but certainly happens. So they need an endoscopy with biopsies, mandatory biopsies, and you should do it if you're a surgeon. You should do that endoscopy because you learn a lot by looking at the anatomy yourself, things that even x-rays won't tell you, and certainly a standard GI endoscopy note won't give you very much information at all. They should have a barium esophagogram. It's a good follow-up tool. It's kind of your basic follow-up tool, and you can use it to assess progression of the disease. Almost nobody ever dies of achalasia, but if they do die, it's going to be because of progressive dilatation of their esophagus. And really that's the surgeon's goal, is to prevent further dilation of their esophagus. So that should be the goal, and barium swallow is your key exam for that. And esophageal manometry in these days, high resolution manometry, is key. That's the diagnostic for this. And people still occasionally will advocate pH studies, but I think that's pretty useless. They're hard to interpret. You can get some information out of it, but by and large, they don't need a pH study. So I think you've all heard about the Chicago classification, now in its third generation. Mostly significant for surgeons. This is a little bit nitpicky, and you have to be kind of a manometry nerd. Like I see Marco Patti in the audience, so he's got bow tie and everything to really get into it. But for surgeons, it does have an impact. So it is good to record what type of achalasia they had when they come in, because as you can see from this chart from Zanonotto, it does have an impact on the outcomes and success rate based on whether it's Chicago 1, 2, or 3. Mostly 3 is kind of the outlier, and I think these patients have to be counseled a little bit different and have to be treated slightly different. So worth knowing, worth boning up on this, and certainly we always encourage surgeons to at least look at the topography graphs, because it gives you an instant, intuitive appreciation for what's going on in that patient's esophagus. And what their physiology looks like and the state of their esophagus has very little correspondence to their symptoms. Very important to recognize. So symptom follow-up, one of my strong themes on this, is almost worthless in achalasia. Patients don't quite know what's going on. Symptoms don't follow physiology, and so you can't rely on it. And then looking at both the degree of clearance of the esophagus and the degree of dilation and tortuosity of the esophagus is very important for many reasons. I mentioned the follow-up. But these examples on the right side are very difficult surgical cases, whether you do them laparoscopically, balloon dilatation, or a poem on these tortuous sigmoid esophagus is really for an advanced practitioner, and you should do dozens of regular achalasia before you tackle cases like that, whether you do it surgically, endoscopically, or other. So I mentioned symptoms aren't great. This is really probably the best that we have for symptom recording. It's always good to document where the patients start from. These patients are not curable, and you can't get rid of 100% of their symptoms. People quickly forget where they started from, so it's good to document when you first see them what their Eckhart score was. A little bit of a crude measure, but at least it gives you an objective, quantified follow-up tool to follow these patients along. So if you don't have this printed out and pin it up in your office when you interview these patients and give them a number. So really treatment, however you do it, of achalasia is quite simple. You have to disrupt kind of the obstructive elements of the esophagus. The obstructive elements can be due to a non-relaxing lower esophageal sphincter. It's kind of the classic thing we think of. Or it can be done due to global spasticity of the esophagus. So if they have Chicago type 3 or a jackhammer esophagus, you have to deal with that element of it as well. You can't just do the outlet part of it because it may only get rid of part of their symptoms. And you can have body dysphagia. You can have food hang up on a barium swallow with solid food in the body of the esophagus if they have global body contractions. Not always, but sometimes. So, really it's a disruptive process. You ruin something that's working too well to achieve a symptomatic result. Achalasia I'm not even going to mention, except that it's to be discouraged. It's not a mainline treatment. It's really a fallback, temporizing measure. We use it occasionally if a patient comes in on the weekend, they can't swallow water, they're dehydrated, we'll use it as a bridge to therapy. So we might Botox them, dilate them a little bit, just to get them through till we can schedule them for something definitive. Europe, where, as you heard, I work part-time, this is becoming increasingly popular. It was originated in China, but placing a stent, covered stent temporarily. They do it for about 7 days in Asia. In Europe, it's typically done for 2 or 3 weeks, and pull it out actually has some pretty good short-term efficacy, but there's not really good solid evidence for this, but you're going to start seeing this appear in the literature and hear about this a little bit more. I'm not going to talk really about it, except to say that this is on the horizon, it's out there, and some people are doing this. And I'd be happy to answer questions about it if you want. Balloon dilatation, I'm also not going to go through. It's really kind of a comparable treatment. It's in the ballpark of what you can achieve with a surgical myotomy, but it requires multiple interventions, sequential interventions, tends to be temporary, and once again, it varies from community to community how accessible this is, and many of the algorithms that are in Europe, where this is done widely, would say let's try one balloon dilatation, maybe a 30 millimeter, and if you don't get a result, refer to surgery. Surgical treatment, of course, has been around for a long time. You're all familiar with this, 1914. Pretty amazing that somebody keyed to it, and of course this has become a laparoscopic procedure since the early 90s. And you're familiar with the history of this, Carlos Pellegrini describing thoracoscopic, and Shimi and Cuschieri describing a laparoscopic many, many years ago now. Over the long term, here's one of my updated references, Gut in 2016 from Zanonotto's randomized balloon versus this, but this is a 10-year plus follow-up. 89% satisfactory results, short and medium term, and even long term. You get a little bit of a fade, maybe due to stricturing, peptic complications, or a little bit of senescence, but still we're looking at a very good result for a functional disease over the long term with laparoscopic treatments. On the other hand, I would argue that, well, this is good, it's still not perfect. So we have a good endoscopic treatment, balloon dilation, we have a good laparoscopic surgical treatment, but they're not perfect treatments and that could always be made better. Balloon is endoscopic, so it's easy, outpatient, inexpensive, pain-free by and large, unless you perforate them. So it works pretty well. Laparoscopic is good, effective, one-stop treatment, but it is a surgery. Patients tend, in our practice, to take a couple weeks off work. It's expensive, and skill demands a fair amount of surgical skill. So it's not a perfect world. Wouldn't it be nice if these two overlapped? And of course, you know about the new kid in the block that was popularized by Pashrika and company, of using notes type technique to divide the circular muscle fibers. Hiro Inoue, a surgeon from Yokohama, that described that first in 2008, a very early experience published in 2000 and end of 2008, and simply tunneling underneath the submucosa, through the submucosa, accessing the circular muscle fibers of the proximal stomach and distal esophagus, and dividing classically the circular muscle fibers alone, leaving all the external supportive mechanisms of the GE junction anatomy free, and doing that. And of course, this started in Japan, but spread like wildfire, and really pretty impressive. And now in many centers, is kind of the primary first approach for normal and complicated achalasia. So it does require a separate skill set. It's a flexible endoscopic, advanced flexible endoscopic procedure. It really builds on the ESD skill set of electrocautery instruments and techniques, and so that's a good way to do into it. Or vice versa, if you're a surgeon, you pick up POEM, it applies likewise that you can treat early GI cancers because you learn a lot about ESD doing POEM. This is kind of what it looks like, and so this is kind of what it looks like. You do an ESD like bleb, make an incision in the mucosa using small electrocautery, monopolar cautery. Tools right now for POEM are fairly basic and primitive, but industry is rising to the challenge, and there's a lot of innovative bipolar and combination devices. You dissect in this kind of interesting submucosal plane. Here, you perform hemostasis and all the usual surgical steps. On the right of the screen, you can see the circular muscle layer highly hypertrophied. And once you reach the end of the tunnel, you back up, and then from a proximal to distal direction, you divide the circular muscle fibers, which you'll see here. And this requires a little bit of care to get down to the right level. It's a little bit, one of the controversies in POEM is whether to do a full thickness myotomy, take the circular and longitudinal muscles. There's some evidence that show that GERD can be slightly higher if you do that. I think it's mostly a technical detail. It's much easier just to go blasting through all layers, and it's a little bit of a finesse and fine motor control to just take the circular fibers. We think that it provides kind of a layer of protection between the mediastinal structures, and teach routinely that it should only be the circular muscle fibers because that has been shown to be effective. We started doing this a while ago at my practice in Portland, and continue to do them in France as well, so a pretty good experience. Standard follow-up. We've been very careful over these early years to get comprehensive follow-up. So we try to get everybody back for EGD, 24-hour pH, and manometry. We have found some cases that are not ideal for POEM. So we still, in our practice, do some balloon dilation, do laparoscopic Heller myotomy with a partial fundoplication, and do POEM. And these are kind of what we found for the relative contraindications. We no longer do patients that have a hiatal hernia of any appreciable size. We don't do POEMs because we found that their reflux was pretty violent, and the hiatal hernia continues to grow. So we think that should be repaired at the time. Of course, if they're not a candidate for general anesthesia, if they need some secondary procedure, if they have gastroparesis and need a pyloroplasty or need their gallbladder out, and more, if their insurance won't pay for it. So in the early years, as you see, we had 100% approval from insurance. This has gone a substantial decrease now, and insurance companies frequently don't pay for it. And it's just starting to change a little bit as evidence continues to build. that this is an acceptable procedure. It's amenable to advanced indications. I mentioned those kind of far outflung, and it's maybe in some ways ideal for some of these. If you have a failed laparoscopic Heller, it makes sense to approach it as you would an inguinal hernia with a different approach, and these are quite doable endoscopically. Even if you have a failed poem, we would tend to give it a second chance, especially if it looked like they had an incomplete myotomy. And panesophageal spastic disorders are uniquely suited for the poem approach because it makes no difference where you start, unlike laparoscopic where you can only get so high. So you can start all the way up at the striated muscle and continue it down. So you can approach these panesophageal spastic disorders with a one-stop thing. So that's probably one of the ideal indications for poem. Operative time is reasonable. Even if you have fellows and residents doing it, it takes usually 2 hours, less than 2 hours to do. Morbidity and mortality is quite low. A conversion rate is almost unheard of, so it's fine to do these in the endoscopy suite. You don't have to do it in the operating room, and you don't have to set up for a conversion to laparoscopy because that's almost never reported. I think one of the most astounding things is this is a rapid and profound correction of their dysphagia. And it happened instantaneously. If you do a laparoscopic Heller myotomy and a partial fundoplication, they have to go through a phase of edema. They have to compensate for the fundoplication, the crural closure, and it takes them a while to really realize the full benefit of the dysphagia relief. Poem is instantaneous. They wake up the next day and they have no dysphagia whatsoever, and by and large have very little pain as well. Kind of blast through this a little bit. Does it last? We're starting to see some early data. So this is 2-year data from European groups and our data as well that showed 96% early success and an 83% success at greater than 2 years follow-up. So we're starting to see some data that this has a fairly good longevity. Should remember that this includes our learning curve cases for all these groups, Thomas Roche and Guido Costamagna as well. Complications are rare and very seldom. There's 1 death reported in the literature out of 6,000 cases that have been done. And then again, works well for that. Non-achalasia, how well does it work for the chest pain group? Traditionally a difficult group to treat surgically. Here you can see 89% relief overall. And if you look at the group of spastic disorders, it's not as good, but it's quite high as well, around 80% for the spastic disorders. So the big controversy, of course, is the reflux disease. Here you'll see an overall 30% incidence of gastroesophageal reflux disease, which is iatrogenic in these patients. And this has consistently been reported, but very variable, from 0 all the way up to almost 50%. On this, and most in the range of most of the literature now is in the range of about 30 to 35% incidence of objective reflux disease. Please note, once again, symptoms in achalasia patients are totally unreliable. If you look at that, 50% of these patients with documented reflux disease were symptomatic. So often the patients that complain of reflux after an achalasia surgery are pH negative, and often patients that don't complain of reflux would be pH positive and probably should be treated. On the other hand, fundoplication, laparoscopic Heller myotomy, and a partial fundoplication isn't perfect either. Partial fundoplications, we know, especially in the obese, are not a perfect procedure, and you can see from some prospective studies from expert groups, reflux in the range of 10 to 40%, probably on average around 30%, objectively tested, pH positive. Once again, many of these patients won't have symptoms, and we know that symptom incidence is only 10-15%, but if you measure them objectively, they can be there. So one of the challenges, of course, for POEM is can we reduce that reflux rate? We've actually been tailoring our myotomy using technologies like EndoFlip, and have brought our incidence down from that high of 47% down now to about 33%, simply by tailoring our tailoring our myotomy length and kind of how aggressive we are at spreading it. How does that stack up? This is a meta-analysis of comparative studies. These are not randomized prospective data, but this is a meta-analysis of the 4 studies that compare laparoscopic partial fundoplication with POEM, and you'll see comparable complication rates, gastroesophageal reflux incidence, comparable, symptomatic recurrence, equal, no significant difference between POEM and laparoscopic hilar myotomy. So they're pretty equivalent, shorter length of stay, less painful. I mentioned the problem with insurance in the United States. This doesn't, of course, apply outside of it, but by and large, most insurance companies consider this an investigational procedure, and many exclude payment for this. Hopefully this will change in the near future as we're seeing some well-constructed multi-center prospective and some 5-year data. In fact, my group in Portland is publishing our 5-year data that show good results out at 5 years at this meeting. So in conclusion, POEM is highly effectable, seems to be durable at least out to 5 years. It's learnable even by surgeons. You don't have to be a master endoscopist to learn how to do this. You just have to love achalasia and be good with your hands, and then we can teach you how to do POEM. Has a similar GERD rate to laparoscopic hilar. It's a true surgery. It's not risk-free and not complication-free. Patients have to be very well worked up and objectively followed forever. Important point, don't rely on symptoms, don't blow these patients off, they're years forever, and insurance companies are complete idiots. Thank you. Happy to answer questions.
Please step up to the microphone and ask your questions. Maybe I'll start out. Lee, can you share with us how you approach the patient referred to you who has recurrent dysphagia after either a POEM or a myotomy? Maybe take both situations. How you approach that, and when do you intervene in those patients? I know none of your patients come back, but from elsewhere.
So there's 2 categories of those patients, either ones whose dysphagia didn't completely resolve, never got better, or only got a little bit better, and patients who are great for several years and then gradually get their dysphagia back again. In the latter category, I think that's just a natural part of achalasia. And in those patients, we do an endoscopy, make sure they don't have a cancer, peptic stricture, active esophagitis. If they do, we treat that aggressively. Typically, we would try just a simple bouginage or balloon dilation to 20 millimeters. And if they don't improve, then we put them through the whole workup again. Barium swallow, time barium swallow, manometry, and a pH study in that case, just to see if they have reflux. If they do, and it appears they have an incomplete myotomy, if they don't get better, incomplete myotomy, we'll discuss quite frankly, if we think that they have reflux disease, we would offer a laparoscopic hilar and a partial fundoplication if we can document reflux. If they don't look like it and they just have an incomplete myotomy, we're happy to try a POEM one more time on those patients and would offer that.
Fantastic presentation, Dr. Swanstrom. Chris DuCoin from Tulane. Quick question. I noticed GERD is a big postoperative issue with these patients, and I noticed it wasn't one of your preoperative kind of contraindications. Is there any comment on that? And then what do you do with the postoperative kind of refractory GERD patients after POEM?
So good question. Technically, if you have a non-relaxing lower esophageal sphincter, it's impossible to have gastroesophageal reflux disease. So these patients often complain of heartburn, but it's probably acidification of poorly emptying esophagus. So we don't bother much about that. The patients that complain of GERD after an achalasia surgery usually had GERD symptoms before, and those can be pH negative. So they don't have it, but they still feel like they have that sensation. So you have to kind of talk to those patients. But GERD symptoms preoperatively isn't a contraindication. And then your other part of your question was?
Intractable GERD after POEM.
So we've had several patients out of that 350 patients that have come back to have an endoluminal anti-reflux procedure. So probably about 3 or 4 patients have had that. By and large, the reflux is easily controllable medically. I'd say about 2/3 of our patients are on PPIs and 1/3 are on an H2 blocker, and easily controlled medically. We put patients that are pH positive and asymptomatic on acid suppression just as a safety precaution.
Thank you.
Lee, did you say you?
Hi, Quan Tran from Tampa, Florida.
One second,
I'm a
let me just
community
ask a
surgeon.
follow-up here. I can't hear you.
Yes. My question is, you know, as a community surgeon, I find myself pretty busy as it is, but I still only do 5 or 6 of these achalasia patients a year. What do you consider the learning curve for something like this? Because honestly, I'm not sure that my ego nor my malpractice insurance could probably tolerate, you know, having an esophageal perforation post-POEM many times.
So it kind of depends where you're coming from. So if you do endoscopy, flexible endoscopy, and
I do a
routine
lot
in
of
your practice,
endoscopy. Yes.
you do, yeah. So the learning curve, especially if you do interventional procedures, ablations, and EMR.
I do the
and-
TIF procedure too, so.
Yeah.
So,
So you could probably learn in 15 cases to do a poem quite safely. Perforation rate is very, very low, even in people's early learning curve. I think if you're a little bit more, if you're in a training phase, probably 20 cases. So if you do 3 or 4 achalasia patients a year, you're probably never going to get over that learning curve and be real facile unless you do a lot of ESD.
I'll send them to you. Thanks.
Renato Soares from Brazil. So thank you for the excellent presentation. The question is about the location of the myotomy itself. So I know that you do it usually at 2 o'clock, but I've seen many people doing it in the posterior aspect of the esophagus. I know the professor Inoue does it at 7 o'clock or something. Do you have any comments on that? Are you planning to change your technique, or why do they do this in a different way?
So there's various theories about that. There's some unresolved issues that people haven't done randomized prospective trials. Some people like doing a 6 o'clock myotomy because it's faster, because it's in the dependent part where the biopsy channel of the scope is. Many surgeons that know what lies outside the esophagus at 6 o'clock, the aorta, are a little bit leery about being aggressive at 6 o'clock. And the classic is between 12 and 3 o'clock, which most people probably is 70% of the myotomies done in that position. There's no real physiologic reason for it. It's superior, so fluid tends to drip down out of your way. It's a little bit of a free area, and there's not big perforating vascular structures coming into the lesser curvature of the stomach at that area. The one area that's difficult to do that almost everybody stays away from is the greater curvature, where you have the angle of His and severe angulation that makes it difficult to do it.
All right. Thank you, sir.
Great. Thank you very much, Dr. Swanstrom.